We'll move on now to Professor Rohit Saxena, who's going to talk to us about approach to a pale or swollen disc. So I think we get to see these both in our practices fairly frequently. So sir is from RP Center. He's a professor there and heading the neuro-ophthalmology services at the RP Center.
Thank you, Digvijay, for the opportunity and AIOS for accepting this course. First, whenever you want to see the disc, it's most important, and we were taught in residency, see a few thousand fundi, and then you'll actually start understanding how to differentiate anatomy from physiology, normal anatomy from pathology. So these are the key things that you need to look for whenever you're looking at the disc: the color, the size, shape, the margins, the cup, the rim, particularly the color of the rim, the shape of the rim, the vessels as they emerge, how they are appearing as they go onto the surface, or they come out of the disc and onto the retina and the peripapillary area. So some are definitions that we'll start off with when we're defining disc edema. So optic disc edema is true disc swelling due to any cause. So there is no etiology associated with this. There is just disc edema. Papilledema is essentially conventionally termed as true disc edema caused secondary to raised intracranial pressure. So there is so we are suggesting in our diagnosis that this disc edema is due to raised intracranial pressure, and pseudopapilledema would be that there appears a disc swelling, but there is no actual fluid edema or anything there. On the other hand, the atrophy. So essentially, the response of the optic nerve, is like a dog. You trouble the dog, little, it barks. A lot, it just lies down and dies. So that's what is happening to the optic nerve. There's edema, initial insult, injury, edema, swelling. It is very rarely that you'll be able to, just on the basis of the edema, get a lot of diagnosis, but it sometimes is suggestive. And over time, there's just going to be atrophy and pallor of the optic nerve. Atrophy would be a pale disc with defective visual function in one form or the other. Again, important thing to remember is that it's just a response and it's not a graded response. So amount of disc pallor or edema may not necessarily correlate with the visual functions. So you have disc edema. The first thing, as we started with, is looking at whether what's happening to the other eye. So whether the disc edema is bilateral or it is unilateral. So if you have a bilateral disc edema, you are more interested to find out a systemic cause. So possibly a systemic or neurological cause may be there. So papilledema, pseudopapilledema, hypertensive retinopathy, occasionally bilateral papillitis, and of course other compressive neuropathies or systemic disorders that could cause a disc edema occurring in both the eyes. When you have a unilateral disc edema, you may tend to get an early suggestion of a hyperemic or pale edema that may be there. Not often very easy to differentiate, but a hyperemic disc edema may be seen in any papillitis, ischemic neuropathies also in the initial phase, pseudopapilledema, CRVO related, or even in asymmetric papilledema where the disc edema starts in one eye and maybe over time will go on to the left eye, to the other eye. And of course, it may be the other eye has an optic atrophy, essentially meaning that this is a sequential involvement of the optic nerves, one eye followed by the other. It's more importantly to differentiate papilledema from pseudopapilledema, so you can see the three things put together, one above the other. So the top one is pseudopapilledema, where you can see the vessels are there. It looks like swollen, but it's a small disc. There is no cup. The margins are not sharp, but the vessels overlying this are absolutely clear. Contrast that with the second slide, where it's absolutely engorged disc. The vessels are not visible. There is an absence of the cup, but you can see the exudates and edema and hemorrhage all over the disc. And again, on the bottom one, you can see that while there is a little bit of blurred margins on one side or the other, but the hemorrhages, the exudates are very far removed from the disc also. So if you have normal retina intervening in clear signs of hemorrhages or exudates, you know that the disc is not primarily involved in that. So this is again another just contrasting between a true disc edema and a pseudo disc edema. essentially, just a quick overview. Papillary edema, a raised intracranial pressure could be multiple reasons, causes. You'll just look for an enlargement of the blind spot and peripheral constriction as the early signs, and over time, it could go on to involve the rest of the entire visual field. The causes could be anything: solid tumors, so you could have raised ICT because of a large intracranial tumor. It could be fluid related, so you could have hemorrhages, bleed anywhere, post-trauma, or again infection that can prevent outflow obstruction. So you could have a hydrocephalus, you could have an aqueductal stenosis causing back pressure, so anything. And of course IIH, which is the most common thing that we see. The most important thing that we're going to look for is an MRI to rule out an ICSOL, and of course look for any other cause. That becomes the most important thing. Followed that up, if the fundus appears to be normal, or there are signs of meningitis, or you suspect, you do a lumbar puncture, and of course work with the neurologist for all this. So neuroimage bilateral disc edemas, rule out ICSOLs, may require a CSF pressure and imaging, and then you manage papillary edema accordingly. Weight loss, very very important. Acetazolamide and increasing doses, the most common ones, and of course surgical options including optic nerve sheath fenestration remains. Just a quick again overview of unilateral. We talked about hyperemic and pale. Sometimes pale disc edema, anterior ischemic optic neuropathy may have pallor associated or setting in very early, giving us a suggestion. But hyperemic disc edema would be papillitis, asymmetric papillary edema, compressive neuropathies. Papillary edema, papillitis, most commonly optic neuritis, but of course unilateral disc edema could be due to anything, any inflammatory autoimmune cause affecting the disc could present with a disc edema or a papillitis kind of picture. Classical features of optic neuritis we have discussed earlier in this conference, and I won't go in details because of the lack of time, but essentially earlier we used to think that no treatment is an option for optic neuritis. Now IV methylprednisolone has become the standard of therapy, and irrespective of the cause, including NMO, MOG, or multiple sclerosis related, our first treatment does become IV methylprednisolone, followed by whatever the rest of the intervention depending upon the diagnosis. A pale disc edema, you're looking at an arthritic or a non-arthritic ischemic optic neuropathy. Non-arthritic forms the sheet anchor of them. It's very very rare to see an arthritic, but it is important to differentiate it because arthritic AION is an emergency. The NAION would present with a little middle-aged or older patient with vision or field loss related things, particularly in altitudinal field loss, a sectoral disc edema, or going on to a sectoral atrophy, and the other eye being a small disc. Whenever you have an NAION, the most important thing is to identify risk factors and manage them, because recurrence in that or the other eye are very frequent unless the cause or the etiology behind the ischemia is managed. Again, essential control of risk factors is the management, and any other treatment has not found to be very effective. Arthritic is just important to differentiate. If you suspect an ESR C-reactive protein which is severely elevated, would give us a suggestion, but any patient, elderly patient with headaches, jaw claudication, sudden loss of, severe loss of vision, scalp tenderness, fever, loss of appetite, all these are suggestions of, so as I mentioned, advanced stage, all these symptoms, initially transient visual obscurations, bilateral sequential involvement, all these are signs. And of course the most important thing is to manage it with high dose steroids urgently, immediately. So that's why arthritic becomes important. Just to show you another ischemic optic neuropathy, you can see a very small Sutton involvement. You can see that the disc is just sectorally involved, and the other eye is a small disc with the absent cup. So these are conditions, again, another appearance of a disc edema. But when you see, we talked about Brusson's in the previous OCT picture, but that's what you need to look out for: true versus pseudo disc edema. And optic atrophy, you can differentiate primary versus secondary, giving us a little etiology based idea. So primary would be because of trauma or issues related to the anterior part. So anything that is causing absence of edema and causing damage to the optic nerve would present as a primary. Clear disc which does not have blurred margins, it's a chalky white disc. Whereas secondary is usually secondary to any cause of inflammation or edema into the optic nerve, presenting with a blurred margin or a dirty looking disc with sheathing of the vessel. So these are possible ways in which we can identify. And another thing that we need to always remember, that there is something that excavated discs need not necessarily be just glaucoma. Even in alcohol toxicities and space occupying lesions, they may present with something like an excavated disc. And it's always important whenever a patient presents to search for the cause of disc edema. So thank you very much for the opportunity and for patient listening.